For today's seminar, we have two presenters, Dr. Amanda Caswell, a pathology staff specialist based at John Hunter Hospital in Newcastle, and Dr. Alan Tankle, the Director of Emergency Medicine at Coffs Harbour Base Hospital on the mid-north coast of New South Wales. Both presenters are very familiar with the often confusing issues surrounding point-of-care versus laboratory-based testing for troponin as a marker of acute coronary syndrome. Dr. Caswell will be presenting several patient cases where troponin results between a point-of-care device and a laboratory device highlight the problems with comparing results from different analyzers with different positive troponin cutoff values. Dr. Caswell will also highlight the problem of how interfering patient antibodies and poor pre-analytical techniques can adversely affect both point-of-care and laboratory troponin tests. Dr. Tankle will then present his experiences around the vigilance required to manage potential HCS patients when choosing to transfer or discharge based on point-of-care or laboratory troponin tests. Dr. Tankle will also outline recent studies from Maxville, a busy mid-north coast regional hospital whose patients and staff have all benefited from a closer look at frontline patient data and their outcomes. Thank you, Amanda.
Okay, so I'm going to present some cases of discordant troponin results that may well have come from an ED somewhere near you. What I mean by discordant troponin results is this. A patient presents to ED, they have a sample run for troponin on an ISTAT, but at some point during their stay they also have a sample sent to the lab to be run on the lab analyzer. But the results are conflicting. Either the ISTAT's negative and the lab results positive, or vice versa. And I think it's fair enough that most people assume in this situation that it's the ISTAT that's wrong. After all, how can you compare that dinky little thing that you can hold in your hand with the big, expensive, shiny lab analyzer? So usually by the time the problem has gotten to me, either want a new ISTAT because they're sure the one they've got is a dud, or maybe they've decided that all ISTATs are duds. So, this all came to a head for me earlier this year. We were getting more and more complaints about discordant troponins, and over about 6 months I'd collected 9 cases across 5 different sites. I've listed them here in the order that they happened. I know there have been more, these are just the ones that I was notified about. Some were concerns about false positive ISTAT results, some false negative ISTAT results. And as I understand it, the concern is that on the basis of a false positive ISTAT result, patients are being triaged as having acute coronary syndrome, or worse still, on the basis of false negative ISTATs, doctors were afraid that cases of acute coronary syndrome were being missed. Now, I'll just say at the start that I am absolutely not making any judgment about the management of these cases. I wasn't there, I don't even have access to the full clinical information. But the number of cases seemed to be escalating, and we felt we really need to take this seriously. Next slide. First, I'll just clarify that all the analyzers in our lab are Abbott architects. Both the ISTAT and the architect assays are immunoassays for troponin I, but only the architect assay is high sensitivity. The two assays are both recorded in mass units, but at different orders of magnitude, because the ISTAT's reported in micrograms per litre, which is 10 to the minus 6 grams per litre, while the architect's in nanograms, which is 10 to the minus 9 grams per litre. For this presentation, I'm going to convert ISTAT results into architect units by multiplying by 1,000. Now, you've no doubt been told that you can't compare the troponin results from ISTATs and architects. But for me, this means we don't expect the numbers to be exactly comparable. But I would have thought, and I think you do too, that if one is positive, then the other should be positive, and if one is negative, the other should be negative. And I say that because the cutoffs are supposed to mean the same thing. They represent the 99th percentile of the healthy population. Or put another way, only 1% of healthy people should have a troponin over the cutoff. So even though the cutoff for the ISTAT at 40 is about double the architect, which is around 20, a positive ISTAT and a positive architect should mean the same thing. I'm going to start with some case examples that were reported to me as false positive ISTAT results. For each case, I'll list all the troponin results, ISTAT in this column. Can you see the arrow? Yeah. And architect results in this column. They're listed in the order that they were collected, but as you know, the architect results may not have been available until many hours after collection. To compare the actual numbers, use the converted ISTAT result in brackets. But if you just want to compare positive and negative over the cutoff, under the cutoff, where the results were reported as negative, it's shaded in green. Where it was reported as positive, the result is shaded in orange. So, if the results are discordant, it's green in one column, orange in the other. Turning to this particular case, as with many, if not all of them, it was the middle of the night. The patient had an ISTAT troponin done at 1:45, and the result was positive at 100. Remembering the cutoff is now 40, so that's a definite positive. The patient had blood taken not very long after, which was sent for a troponin on the architect, but the result that came back from the architect was a very low negative. What's happened here? Well, the most likely explanation is that the ISTAT result is indeed a false positive, probably due to something that happened to the sample before it was even run through the ISTAT. So there's some sort of what we would call a pre-analytical issue. Next slide. And I'm even more convinced about that because we actually had 2 cases like this at the same site on the same night. In the first case, or in this case, the first ISTAT result, just after 5 in the afternoon, was nearly 200. But the next ISTAT was negative. So one of them's wrong, but which? As it happened, a sample had been collected here on presentation to be run on the architect, but the ED staff didn't get the result until 2 in the morning, and it was negative, very low. So I think that this one is a very fair call to say that the ISTAT of 200 was a false positive. Next slide. This is a very similar case from a different site, ISTAT about 200, architect negative. Next slide. And another case from the same site as the last slide, but many months later. Again, ISTAT around 200, but low architect results. Actually, some of these architect results are just over the cutoff for females, but clearly not consistent with this ISTAT result that's way over the cutoff. Now, none of this is very surprising, because we know for a fact that sample problems can cause false positive results on an ISTAT troponin assay. What we're talking about is microclots that you can get if you happen to draw the blood from the patient a bit slower than you might normally, or if the blood that you used in the ISTAT is actually being taken from a green top tube, a lithium heparin tube, but if you haven't added enough blood to the tube, there's too much heparin in the sample. What happens is that any little clots, or if you've taken it from a tube, the excess heparin can somehow create a bit of noise or background interference in the analysis on the ISTAT, which wouldn't be significant in a patient who really did have a very high troponin. But if the patient's true troponin level is actually very low, then sometimes all you're seeing is the noise. And if you're not convinced, play with an ISTAT and see if you can falsify a result, like we did one day in the office. Next slide. So our registrar took a blood sample from me. First we ran it on the architect and the result was 1. Then we ran it on the ISTAT and the result was 10. So about as low as you can get. Then we tried a few things to bugger it up. And it only took us 3 attempts to get me a troponin result of 130. Bingo, I believe in false positive ISTAT troponins. We did this by using blood from a green top tube, but we only put 0.5 ml of my blood in the tube instead of 2 mL. And that's why at sites where they're getting a lot of false positive ISTAT results, we say we probably really need to check the collection and testing technique. But maybe all positive ISTAT results that aren't consistent with the clinical picture should be confirmed on a careful recollect and rerun on the ISTAT. I'll just make the point that noise at low levels is an issue for all immunoassays, but with the high sensitivity Troponin Lab assays like the Architect assay, somehow they've been able to eliminate that noise, and that's how we can report results down to very low levels and be confident that it really is troponin that we're measuring. Now I'll show you one more example of a false positive ISTAT troponin that we think might be something else, something that's unavoidable, but fortunately not common. In this case, we had a very negative Architect result, but a very positive ISTAT result at 840. This is way too high for the usual pre-analytical noise. But there is another possible explanation for it. You may have come across a form of interference that can affect any immunoassay. The patient just happens to have an antibody in their blood that reacts with our assay, with our test. We talk about heterophilic antibodies, and they can cause a false positive. In this case, to be absolutely sure, we ran the sample on a troponin T assay as well. As you can see, the results are essentially the same as the Architect. So, 2 out of 3 assays were negative. It's almost certainly a negative. Now, there's nothing particularly extraordinary about the ISTAT giving us this result. Heterophilic antibodies can affect any immunoassay, but it's just something that we need to be aware of. And in this case, we recommended that this patient should not have troponins done on the ISTAT in the future. I'll move on now to the issue of false negative ISTAT results, or should I say presumed false negative ISTAT results. A more worrying scenario. I have 4 examples of that. Here we have a negative ISTAT result, and then an hour and a half later, a positive Architect result. Has the troponin risen this quickly over that time? Well, with the benefit of hindsight and subsequent stable Architect results over a period of 8 hours, I think it's fair to assume that this patient's troponin may very well be around this level pretty much all the time, or it's been pushed up by whatever illness brought them to hospital. But this is not acute coronary syndrome. Now, it may not be acute coronary syndrome, but it certainly looks like a false negative ISTAT. But at this sort of level, less than 100, the ISTAT is not necessarily going to get it right. And again, we've known about this all along. It's, in fact, inevitable this will happen. I'm going to show you a correlation of ISTAT versus Architect results that was published in a document endorsed by my mob, the AACB, the Australasian Association of Clinical Biochemists, a couple of years ago. So, they ran patient samples on both an Architect and an ISTAT, presumably under ideal conditions, so we're not seeing any pre-analytical effects. The x-axis is the Architect results, the y-axis is the ISTAT. You'll see that both are in log scales, and they've put a line where each assay cutoff is. So there's the cutoff for the Architect, there's what is now the cutoff for the ISTAT. There's the old cutoff for the ISTAT. To make this easy for us, I've coloured in the spaces bound by the cutoff lines. So in the top right in green here, both the ISTAT and the Architect are positive, what you want. Down here in green, they're both negative, so all good. Here in red is a group of patients who have positive Architect results, mostly under 100, but who were negative below the ISTAT cutoff. What this says to me is if you're talking about low-level troponins, by which I mean under 100, it's not at all surprising that the ISTAT might be negative and the Architect positive. That's exactly what we expect to see. Which is ironic because, of course, before I was saying that the ISTAT can give you false positives at low levels due to clots and so on. And here we're saying you can get false negatives at low levels. So it's not even very good at detecting real troponin down at these levels. In pathology lingo, you'd say that the I-stat is simply not precise at low levels. And in fact, that's exactly what the manufacturer tells us in their pack insert. Next slide. So, on the x-axis here is the troponin level. This is how they expressed it in the pack insert. I've converted it to the units that we're talking about here, 150. On the y-axis is a measure of precision. Don't worry if you don't know what a CV is. It's like a standard deviation, if that helps. But what it means is this. Basically, if you run a sample, the same sample, on an assay many, many times, you do not expect to get exactly the same result every time. But if the assay is very precise, then the results will all be pretty close to each other. And in those cases, the CV will be low, so low is good. However, if you measure the same sample on the test many times and the results turn out to be quite scattered, a little bit all over the place, that's a less precise assay with a high CV. High is bad. Now, as a general rule, for all of our lab tests, sort of as they get down to these very low levels, you expect the assay to become less and less precise. So the lower the result, the higher the CV. So this is what we expect to see. Now, we used to say that the troponin cutoff that you choose should be at the point where the CV is about 10%. So if we went by the old rule, at 10% we'd be looking at a cutoff of about 100. For point of care troponin, people seem to accept a CV of about 20%, and here we see that the CV at 20% is, well, somewhere above around 50. Remember that we're now at a cutoff of 40, and extrapolating the CV is going to be way up here somewhere over 30%. For those of you who are not pathology people, that sort of imprecision would simply be unacceptable on a lab analyzer. What I'm saying is, the bottom line is that troponins under about 100 on an I-stat are pretty dodgy. And I have some cases illustrating that. Next slide. So this case spans 2 presentations over 2 days. This last extremely high architect troponin on the 7th of October, the gentleman was actually having an infarct. The concern is what was going on in his initial presentation the day before. So if you look back the day before, you'll see that there were 2 negative I-stat results and 2 positive architect results. But of course, when they were dealing with this patient overnight, they didn't have this positive architect result. All they had were these I-stat results. So the concern was, had they missed this big infarct back here because all they had overnight was the negative I-stats? Now, I should clarify that this all happened just before the I-stat cutoff changed from 80 to 40. So had this happened a few weeks later, those I-stat results would actually have been positive. But anyway, we got an architect result of 90 and an I-stat result of 60. So in this case, is this a false negative I-stat? Well, yeah, but it's just the I-stat doing what I-stats can do at this level. It's giving you a ballpark result. It's telling you the troponin's up, it's under 100, and that's probably about all you can really be sure about. Even so, once they had this architect result of 62, so they're going from 90 to 62, I don't know that that's really very convincing for acute coronary syndrome. And frankly, I think it would be fair to explain those architect results as fluctuations in troponin in a patient who may have an elevated troponin either all the time or as part of a current illness. And this infarct is sort of happened here after that second architect result. Next slide. And I think this is the same phenomenon again. So this time all the I-stats are negative, all the architects are positive. But does this mean that the I-stat was missing an acute coronary syndrome? Again, the architect troponins are all under 100. But look again at these architect results. The first one's 55. In 18 hours, it increases by 41%. A borderline increase at best for a diagnosis of acute coronary syndrome. And when you see that the subsequent troponins are essentially unchanged, it looks to me again more like this is a troponin that's chronically raised or raised in the context of this illness. What I'm saying is that even though the I-stat might be, the exact number of the I-stat might be a little bit dodgy if we're at these low levels under 100, does that mean it's missing acute coronary syndrome? Or is it just missing the fact that this is a sick elderly person whose heart is compromised, and really we knew that without the blood test anyway? And as I was thinking about this, a colleague sent me this paper. It's one of those papers that makes so much sense you wonder why someone didn't write it sooner. Basically, it's making the point that the troponin cutoffs we use for high sensitivity troponin assays are probably way too low for many of our patients. That the cutoffs we use are based on troponin levels in, air quotes, healthy people. But of course, many patients who come through our EDs are old and sick and may have chronically raised troponins. Maybe the right cutoff is actually closer to 300. Or maybe we need not just a second troponin, maybe we need serial troponins to document a low-level fluctuating troponin. Basically, I think we need a more nuanced approach to thinking about lowish troponin levels. And I am sure that's mostly what's happening out there, but I think we need to find a safe way to put that nuance into our protocols if that's possible, because that's a matter for clinicians, ED and cardiologists, not pathologists. But finally, one more case that may well be something very different again. Here we have negative I-stat results, with architect results almost 200, demonstrating a rise, albeit a 3-hour rise of only 18%, from 166 to 196, so not necessarily acute coronary syndrome. But this time, think outside the square. Are we sure they're false negative I-stats? Or could they be false positive architects? Now, I hadn't been looking at these cases that way. Like our ED colleagues, I'd been assuming that the I-stat was always the one in the wrong. As I did at first with this case when I got back from leave after the January long weekend and got this email. But then I got caught up in a long string of emails between chemical pathologists all over Australia and New Zealand about something I'd vaguely heard of before but hadn't really paid much attention to. It seemed a lot of people believed they were seeing false positive troponins on the Abbott architect assay and other high sensitivity lab troponin assays due to macro troponin. Now, not just one. You may have heard of macroprolactin, macroamylase, macro CK. This is the same thing. It turns out that a lot of people make antibodies to their own troponin, maybe around 15% of the general population. These antibodies can bind to troponin in the bloodstream to form a big complex called macrotroponin. And because the body doesn't clear the troponin out of the circulation as quickly as it can the normal troponin, it accumulates. So if the troponin assay that you're using detects that big complex as if it was regular troponin, then you will measure a high troponin in that patient. Effectively, clinically, a false positive. Now, macrotroponin has always been there, but it may be that we've only really become aware of it since we've had high sensitivity troponin lab assays. It may be that whatever they've done to tweak these assays, they're now detecting the macrotroponin, whereas the old assays didn't. Some research out of Brisbane suggests that macrotroponin may account for about 5% of the cases of rose troponins on the Architect assay. And most of these falsely raised results were in the ballpark of the lowish levels that we're talking about today. Interestingly and importantly, according to the iStat manufacturer, which is, by the way, also Abbott, macrotroponin does not seem to be picked up by the iStat. Hence the possibility of a true negative iStat and a false positive Architect. It's a big problem that I'm afraid we don't seem to have any easy answer to just yet. Next slide. So to summarise, I think we are seeing discordant troponin results. We can tackle the false positive iStat results by being aware of the pre-analytical issues. We also need to be aware that we expect to see false negative troponins on the iStat when we're talking about these relatively low levels, say under 100. And I also think we need to be careful about diagnosing acute coronary syndrome on the basis of low-level troponin rises in older, sicker patients. But finally, be aware that Architect results can be false positives too, and it may be more common than we think.
Okay, right. Thank you, Amanda. We're now going to pass on to Alan, who will actually give some of his experience regarding point of care and troponins. So, Alan, do you want to go from the current slides, or do you want to load up your own slides?
No, you can load up my slide. I'll just tell you next slide. So if you want to start on my first slide, yep, that'd be fine.
Okay.
So if you go on to the next slide. So I live in Coffs Harbour, and we have a network of 3 peripheral hospitals, which are Maxwell, Bellingen and Dorrigo. In Coffs Harbour, we see around about 40,000 emergency department presentations a year, with a 35% admission rate and about 25% of which are paediatric. And just for your interest, we actually have the highest trauma load in New South Wales outside of Sydney. This is a big, busy regional emergency department. Maxwell is about a 35-minute drive away if you go at the speed limit, and they see about 13,000 presentations a year, and we see about 2 or 3 transfers a day from there. They used to have an on-site lab, but that was closed for financial reasons about 5 years ago. It was a business decision, which you can argue with, and they're now completely dependent on point-of-care testing. Next slide, please. Next slide, please. That's it. So they perform around about 500 point-of-care tests per month, and they've got 3 devices. So they've got an iStat, they've got a CoaguCheck, and they've got a HemoQ. So on the iStat, they've got the Chem8 Plus, which many of you will be familiar with. They've got the CG4 Plus, and they've got the Troponin I. They also have a CoaguCheck, and they have a HemoQ, and overall about 500 tests per month. Next slide, please. So I want to talk about Troponin I in particular and comparing the point of care versus the laboratory test. Now, it's important to understand some basic definitions, and the point of care Troponin I is a standard, what's called a standard sensitivity test, whereas the lab-based, the Architect high sensitive troponin is a high sensitive troponin. Now, one is expressed, or the point of care testing is expressed in micrograms per litre, and the other in nanograms per litre. They're both Troponin I, there's a difference of 3 decimal places. And that's a very deliberate reason. And that Abbott make both tests, they make both the iStat and the Architect, and basically they don't want us to compare them for particular reasons. And basically because the antibodies that are used to detect the Troponin I in both of these tests are picking up slightly different epitopes. So there will be marginal, not huge, but marginal differences. And there's also different, what they call different analytical sensitivity and diagnostic accuracy. The other important point to understand is that the cutoffs are different in these tests. So with the high sensitivity troponin, it's 26 nanograms per litre for men and 16 nanograms per litre for women, which is 0.026 and 0.016 micrograms per litre. And compared to the iStats test, that's 0.08 micrograms per litre. And that's interesting, and there are reasons for that. Next slide, please. So, in terms of the reference range for the iStat, I had always presumed this was done in thousands of normal people who were known to be normal, and that they had picked off the cutoffs from there. It turns out that is not the case. If you look at the iStat product leaflet, what they did was they looked at 162 what they described as apparently healthy donors. Basically, they were the people who were working for iStat. It was the people in their office, and they weren't properly screened. They weren't in any way the demographics looked at. We don't know how many of them had heart disease. And what they were able to demonstrate with these 162 people was that 97.5% of the troponins they did came in under 0.03 micrograms per litre, and 99% came in at 0.08. They then had a chat with their local friendly cardiologist who thought 99% was good, and that's why the cutoff point for the iStat is 99%, is 0.08 at 99% of the patient population they chose. What they also say as their disclaimer is each facility should establish its own reference range using the iStat, CT and IASI. Now, I have talked to many of my colleagues. I don't know a laboratory in the country that has actually gone to the effort of doing that, and I don't see anybody starting to do that now. So next slide, please. So what happened in Maxville is that we do have staff specialist emergency physicians down there, and one of them noticed that there was some significant problems with the different results from the lab pace test compared to the point of care test. And essentially they had 9 in a short period of time, 9 false positives and 5 false negatives. And that one of them had a high sensitivity troponin of 113 compared to a negative stat of 0.08. And that's clearly clinically potentially very important. So next slide, please. These are the discordant results, so I'll just let you have a look at these for a second. So there are some false positives, there are some false negatives, but there are significant differences which causes certainly a lot of us some very significant clinical discomfort. Next slide, please. So we did a retrospective audit and we looked at 50 iStat results and matched them with the high sensitivity troponin after these patients had been transferred to Coffs Harbour. In that particular retrospective audit, in that particular cohort, there was 2 false positives, 7 false negatives, giving us an 18% error rate. Now, one of the false negatives subsequently was found to have a 100% LAD lesion. What that is, for those of you who don't know, the LAD is the major artery supplying your heart, and that to have a 100% lesion, that's absolutely life-threatening. This patient did come back with recurrent chest pain, did get transferred to Coffs Harbour, has had a good clinical outcome, but might not have had. Next slide, please. So I had a number of conversations with people, and I went through a process in my own mind, but talking to people about what the possible explanations might be. And it crossed my mind, maybe we've got an old machine which is past its use-by date. Maybe it was being inadequately calibrated because people just don't understand how important the process of calibration is. That maybe the cartridges were faulty. Maybe they haven't been kept within the appropriate temperature range at all times, because it turns out that that is very, very important. And that maybe the staff were just not using the machine correctly, and didn't understand the process and hadn't been trained correctly. And all of these things were possible in my own mind. Next slide. So in terms of technique stuff, the venipuncture technique is very important. And hemolysis is common in people who are maybe difficult to cannulate, or if you're taking out of a very small cannula, or it's just been proving a little bit difficult. And grossly hemolyzed samples will cause a falsely low troponin I. Equally, if you don't invert the tube gently after taking it and putting it in your purple top, then you will get clotting. Now, as it happens, I've been around for well over 30 years, and I have always inverted about 8 or 10 times when I've been taking blood. It's something I grew up with when I was a wee boy. It's something I've always done. But when I look at other people doing it, many people do not do that. And they sort of they may or may not have been told, but they don't think it's important and they don't do it. And what we do know is that partially clotted samples cause a falsely elevated cardiac troponin. There's also issues about delays in sample processing that I'll talk a wee bit more about later on. Clotting does not affect the lab paste tests because these are all centrifuged prior to testing, and that gets rid of the clotting problem. Next slide, please. So it turns out that the iStat machine in Maxwell actually wasn't an old machine. It was a new machine, and it had been commissioned in September of 17. It was being checked every day by an accredited person. It was having a monthly quality control. It was having bi-monthly QA tests. And the cartridges were being stored as per the product information. And the staff were trained. They do have to pass competency tests. They do have to complete an online module. And as it also turned out that Maxwell had the lowest error rate in the state at 1.5%, where the state average was 5%. So in fact, the way that we were doing it was actually very, very good. And the other nice thing about the iStat is that when there's an error, it tells you there's an error. It does not give you a result. Next slide. So what does this matter? And so from a false positive point of view, it means that patients who do not have the disease, who do not have an acute coronary syndrome, are necessarily transferred. That's a cost to the healthcare system, but it's a cost to them personally, because not all of them will get a free lift back to Maxwell. And it also affects their families and their ability to pick up their children or whatever it is, but these have a personal cost. In terms of what happens in Coffs Harbour, that's more patients than we need to have, and that impacts our ability to manage our patient flow. It increases our access block, which is our ability to get patients to the wards for those who require it, and it affects our KPIs, that upsets our administrators. It's the clinical stuff that upsets me, but the KPIs to some extent do reflect the clinical impact. In terms of false negatives, however, that really does matter. And we risk sending people home who have the disease, who are at risk of a major adverse cardiac effect, who absolutely could die because of this kind of event happening. I certainly have, in Coffs Harbour, seen patients sent home with negative troponins, negative ECGs, awaiting their formal stress testing, who die within a couple of weeks. That's happened in my environment. This is real. This matters. And so the question then arose to us is whether we can manage this group of patients safely in our peripheral hospitals using iStats. Next slide, please. So we did a prospective study, and what we basically did was we did 249 paired samples. So the same blood sample that was used for the point of care test was used for the lab paste test. They were all tested within 2 to 30 minutes, and 2 to 30 minutes for the point of care and 1 to 12 hours for the lab test. The iStat negative was 0.08, although that's recently changed as a result of this. And the lab sample was negative of less than 16 nanograms per litre for females and less than 26 for males. We provided this information to the manufacturer and to the New South Wales Health Point of Care Testing Advisory Committee, on which I sit, so there's a conflict of interest there. We haven't formally published these. Next slide, please. This is the table, the crossover table. So just feast your eyes on that for a second, and if we go on to the next slide, I will explain all that. So 87% of the point of care tests coincided with the ISTAT, and that coincided with the lab, and that's absolutely fine. 10% were false negative compared to the lab PACE test, but all 24 of these had a high sensitive troponin of less than 80, i.e. it was between 16 or 26 and 80, which is equivalent to 0.08. So this was about differences in the reference range, and that matters. But 3%, which is 8 patients, not a small amount, were false positive. Next slide, please. So these were the false positives, and so there's quite significant differences there between the ISTAT result, which got as high as 0.42, and the lab results that were all under 6. So that's interesting. Next slide, please. So there has been lots of discussions at the clinical, at the point of care test advisory committee, and the decision was made to bring the clinical decision point down to 0.04 rather than 0.08, and that began in November of 18, and that's in line with what Queensland is doing. It slightly irks me that Queensland did this first, and I hope it irks the rest of you as well. In terms of sample handling errors, though, what did happen is that we've reduced these very significantly. If we get an unexpectedly high ISTAT troponin, because we do tests in patients that we expect to be normal so that we can safely send the patient home, that's good medicine, it's good emergency medicine. If we get one that's high that we really don't expect it, we repeat it and we make sure the test is done absolutely perfectly and that it's done within 2 minutes. Every single time we've done that, it has returned to normal. We've not had any more false positives or any more false negatives since we began this study. Next slide, please. So we need to understand a few things. We need to understand how the reference range is derived. We need to understand what the universal definition of AMI is, and that includes one troponin above the 99th percentile. So I would argue that the reference range that was derived for the ISTAT was absolutely inadequate and it doesn't pass the sniff test or the pub test. If we are also going to rely on point of care testing, we need to know what the error rate is and whether that falls within what we regard as an accepted margin of safety. And technique really, really does matter. Now, the fact that techniques matter so much is a problem because it means that the test is not as robust as it should be. We have to absolutely assiduously make sure that everybody who does this is properly trained, that they maintain their standards, and that they do the test properly every single time. When the test is done properly, the results are believable, they are accurate, and I am certainly confident that I can act on them. However, does that happen in every small hospital every single time around New South Wales? And I think that is a very real problem for us as clinicians, that many of the tests that are being done, I think, will never be able to be completely believed because of the fact that we are so dependent on the quality of the technique rather than the quality of the machine. And just remember that troponin I is an organ-specific test, not a disease-specific test. There's lots of causes of troponin I elevation that are nothing to do with cardiac disease, and it's because of increased cell turnover, and so things like sepsis and tachyarrhythmias and pulmonary emboli, and indeed extreme exertion, falsely elevate your troponin, but they're not really falsely elevating it, they are just elevating it for good clinical reasons. Next slide, please. And that's me done. So I'm happy to answer any questions on any of this, and I'll hand this over to Julie.
So I'm not sure if Julie's experiencing a technical difficulty, Alan, but I just wanted to thank you and Amanda for wonderful presentations. I'm not sure if any of the other guests online want to comment, but it's a great opportunity. A bit of a shy audience. Alan, I think we're very lucky to have you and Amanda presenting from both sides of the fence, so to speak. How did you know in the slide before the question slide, did you continue repeat testing, so performing the point of care and the lab testing at the same time? So there might be a slide again earlier.
No, we didn't. So what we've done is that we have looked at the patients that have come up to Coffs Harbour since then and identified and continue to audit whether there's any problems or any disparities between the tests that we've done down in Maxwell and up here. So it's a continuing observational period, and there's been no more false positives or false negatives because all of the potential false positives are being picked up in Maxwell before they send them up. And the ones that they think might be almost always are, and when they repeat the test, it comes back as negative.
So the way I read it, and I always read it from the positive angle, unfortunately, and people can read it differently, the reduction to 0.04 has helped a little, and the improved pre-analytical focus has helped a lot.
Yeah, that's right. I'm just also noticing Helen Westerway's asked a question in the chat room and about the repeat testing being routine for unexpected positive. The answer to that is yes, and it is a matter of course now in Maxwell. And I think this is the kind of thing that should be copied elsewhere. If you have an unexpectedly high troponin and you weren't really expecting it, but you were doing it for good clinical reasons, is repeat the test and believe the repeated test, but pay very good attention to your technique.
Thank you, Alan. Terry here. Yes, I think one of the things we've always had out there, and it's on our procedures as well, is that we say that if you get an unexpected result, to always repeat it. I think what this shows, though, is that we really need to re-emphasise that when we're doing our training, to say, look, it's an important reason why we say this, and not just to add it to all the other things you have to remember. So I think that's a good outcome from this.
Yeah, Terry, it's Brian, and I think we need to also stress that not just troponin, you need to repeat any test that doesn't fit the clinical picture.
Yeah, no, I guess
potassium comes to mind as a very critical one.
Yeah, and the other thing to add is to not repeat the same sample, because you'll only get the same result. It's likely to be the sample, so go with a fresh sample when you do the repeat. That's very important. And I'm guessing that's what's happening at Maxwell.
Yeah, that's right. Somebody called Dan has asked a question in the chat room about a recommendation that troponin should always be tested after the CG4. I'm not entirely sure what he means by that, and I'm guessing what he's meaning is that when you take some blood, you do the CG4 test first, which will actually delay the time to doing the troponin. Am I understanding that correctly?
That's correct, Alan.
So that might be a problem. So I'm presuming that the CG4 test is also very time sensitive as well. Is that correct?
Yes, the gases particularly will dissipate out of your sample if they're not done first. The way we've got around that at Maxville and most of our high use sites is we try to put a second istat in. That way you can start your CG4 on one, start your troponin on the second one at the same time. Okay. That prioritises things.
So I think if you don't have two istats, the answer for that is that you do the CG4 first, because that's obviously critically important. And if you get a false, or what might be a false positive in the troponin, is simply to repeat it.
Yes, the recommended time frame for the troponin to be run after collection is 30 minutes, but obviously the sooner the better.
No, well, I think the evidence that we have is that if you can do it within 2 minutes, it's more likely to be reliable, and between 2 and 30 minutes, the risk, it doesn't suddenly increase at 30, it's obviously a continuum, and I think the quicker you do it, the better.
I think that sounds like another little study, Alan. Okay. Okay, does anyone else have any other questions for Alan or Amanda? I think it was interesting that a lot of the data between the two studies were really showing that variation up to 100 on the ISTAT, which is very interesting. It does tend to match up quite well. It is very wobbly in that area. Okay, I think that sounds like it's a wrap. Thank you very much, Amanda and Alan, for your excellent presentations. I think we've learned a lot and appreciate everyone dialing in and listening. And I'm sure Julie will tell you that this presentation will be available on the New South Wales Health Point of Care website shortly. I'm not sure if the last of these slides has that address on there, or we can put up something on the screen that shows where that address is. There we go.